And without further ado, I'll just introduce our speakers today. So I'm Grégoire Lurton. I'm working at the data science lead at Blue Square. And I'm happy to be introducing the three speakers and our discussant for that session. We will be first hearing from Dr. Boukari Ouedraogo from Burkina Faso, where he's heading the National Health Information System there. I'll be talking about how strengthening capacities for data analysis has been prepared in Burkina Faso. We'll then hear from Moussa Lee from JSI, presenting on some tools to visualize and mobilize the data for malaria. And then we hear from Aaron Fang from Brown University, and he will be showing some work that he's been doing in DRC on how to think about and how to improve data quality and utilization of data coming from national health information systems. Then Dr. Karen Grépin from the Hong Kong University was kind enough to accept to be a discussant for the session. We'll be addressing and responding to those presentations and introducing the Q&A session for us. So without more expectations, I think I'll introduce Dr. Boukari Ouedraogo, who will be talking right now about capacity strengthening for health systems in Burkina Faso. Boukari.
I will do my presentation in English, but the slides are in English, so it'll be perhaps a little bit easier for you. I'm Boukari Ouedraogo. I'm the Director of Health Information Systems, and I will be looking into the improving of data quality, particularly for the Burkina Faso, particularly on the capacity building. This is just a map for you to visualize Burkina Faso, 274,000 kilometers for a population of over 21 million. We've got 70 health districts to start. At the level of the organization of the surveillance system, we've got a pyramidal system or similar to other organizations of other health systems. The surveillance of malaria is part of our health surveillance, and it is on a community level, health centers, health districts, and all the information are collected from these grassroots levels. We have a continuum of care with strategies put in place by the Ministry of Health so that malaria can be taken care of for children, particularly for children under 5 and pregnant women. We need to reinforce the oversight because on top of the basic surveillance, with a strong contribution of community health workers, we have also an oversight for or sentinel surveillance systems for other illnesses, influenza and arbovirosis. We have a number of tools to use these data that are transmitted every week. And we've got several platforms, THLO and DHIS2, and One Health electronic platform. This slide as a way of introduction to the apps particularly for malaria. You will see that for DHIS2, we've got ENDOS for monthly data. We also have One Health, which is an instance of a DHIS2 with other pathologies. And we've got WAHO, where countries can get regional information. On top of this DHIS2, we've got EpiInfo for a number of analyses of disease. And then we've got also Excel, which is most used. All the regional, the districts send to the regional, to the region. And then we've got SetLab for the collection and the transmission of lab samples for the districts. For all this array of apps, in Burkina, we felt it was important to strengthen the skills of the health actors, because we wanted to identify the primary cause for lethality and mortality. We identified a number of needs at the level of the training, health training and other structures. We noted there was insufficient skills and knowledge regarding all these e-health tools. And with all these data systems, sometimes it's very difficult to get to be understood, because we've got databases and how we aggregate all these data. And that's why it's important to build up the capacities. And to achieve this, we realized that there was a number of restructurations, a number of resources that were necessary. First, human resources, with epidemiologists with incredible skills and knowledge, which could be there to reinforce the capacities. And it goes with the necessity to have a number of material resources, which can be the databases, the servers, and of course we needed financial resources. The final point was for us to examine which academic structure could support and train the actors. For this, we proposed short and long-term training programs. These short trainings, we emphasized the need to have training that would be recognized nationally and internationally, so that we would have knowledge that could be useful and usable for the various actors. We worked with a private institute, and this very first experience was to reinforce the management of the quality of data. For long-term training, we wanted to put in place master's degrees in medical informatics and data science. Here are some of the modules that are being developed within this master's degree. We've got specialists who are based around the world, in Europe and Japan, who we try to tap in their knowledge and their capacity to help us out. So we wanted to We started this master's degrees in 2019. So many nationalities are involved in West and Central Africa. The training should allow for people who are in full-time employment to be able to study, and so that knowledge, and because we can download these trainings so that people at work can actually do the studying at their leisure. So we've got a lot of vertical database producing data, and we decided to establish a university degree with 3 modules for over 5 weeks. DHIS2 over 2 weeks, from the installation to the creation of the forms, that in 2 weeks. Then 1 week with Power BI for everything that is upload of data and publications, and we use specific language. And finally, a module with a week and a half when we use the demographic health survey for over 2 weeks, and we teach how to deal the variables and analyze them, and how to use the DHS platform and we finish with the dashboards. So this is the length of the training for our actors. For a long-term training, for short-term training, at the level of the Ministry of Education, the profile of our usual students have to have a minimum of a degree, and we opened the training to students in mathematics, and here is the profile for different countries, for Togo, Côte d'Ivoire, Benin, DRC, Djibouti, Chad, Senegal, Guinea, Cameroon, Mali, and Niger. For the students, we noticed that the DU, university degree, we had 2 Ivoirians who were able to integrate the international organizations through the degree that they took. So at the level of the DU, students are really doing well with deepening their knowledge. For the masters, we had 2 cohorts with 47 people. The next session will be held in 16th of May to the 17th of June. It's 5 days a week, from Monday to Friday, 5 hours per day, and we use an e-learning platform. To finish, I would say that using health data is a challenge at all levels of the health system. So it's not specific to Burkina Faso, frankly. Also, there are recurrent changes of the training actors. These changes show that it is important to have a system that is enabling and reinforce the competence of the various actors. We noticed also there was a dearth in the culture of analysis and systematic use by field actors. Training had to be more practical than theoretical. What we suggest is that we carry on with the assessments and facilitate the revision of various schedules for institutional constraints. Also, we want to improve the capacity of actors at all levels for the health pyramids in order to be able to make decisions on the basis of common learning. On top of that, it's important to be able to upgrade the statistical analysis so that the various actors are able to interpret these and take decisions. And the advanced knowledge of statistical analysis tools is essential in order to improve the quality not only of the data, but the quality and the decision for the health of the population. Here is the end of my presentation. I hope I was clear, and I'm really sorry if some areas were not as precise as they should be. Over to you. Thank you very much, Boukari, and thank you for your presentation.
I think it was a great start to see, the efforts and different domains and how thinking about strengthening capacities to work with data in complex systems like Burkina Faso could look like and what the type of structures are. And now we have two presentations showing the type of tools and work that the people that go through those training may have to be working on. So our next presenter is Moussali from John Snow Incorporation. And he'll be presenting on a tool that has been developed by his team to improve the analysis and understanding of data in the programs where JSI is working. Moussa, please, the floor is yours.
Thank you very much for attending this session. So I'm in JSI, John Snow Incorporated, but mainly in a project that we call PMI, Measure Malaria. So, and this project is helping the ministries of health in countries where we are working, how to improve the malaria information so that it will help the decision making. So, but how can we came into these mobile applications? Because we have realized that health facilities are collecting data and reporting data to the district level, but that data does not come back to them in form of information. They have it in crude data, and then we said, okay, so we need to do something for them also to be using. But there are many issues that these health facilities have. So, and we said, okay, so since now, everyone, wherever you go in the countries, so you will find mobile phones or tablets and whatever, the people are using that. And for that also, internet providers are providing 3G or 4G all over the country. The coverages are enough for others to use these cell phones. So we said, okay, let us develop a mobile dashboard, scorecard applications. And what motivates that is to enable health facilities to access the malaria information, because we are working in a malaria, and to increase immediate review and analysis of malaria information at health facility, and improve the use of malaria information, and development of by creating or developing plan of actions. And that tool recently is being implemented and adapted in Madagascar and Cote d'Ivoire. But I'm going just to show you that the assessment that we did, the assessment of the use of the mobile in Madagascar, since the Cote d'Ivoire one is still ongoing. So our approach to be implementing that was to be developing a generic dashboard and scorecard mobile applications. And that's, we wanted to be using the WHO indicators. But in doing so, we thought when you go to the countries may have their own information need, which we need to be doing. Okay, and that participatory approach that we want to be implementing will help the country to be selecting the indicator that they think this is what is their target, and this is what also they are monitoring to see if they are making progress in implementing their activities. And also involving the DHIS administrators for them to be able also to take over these applications for sustainability, and then piloting it in one district to learn from it what have been done and what progress and what needs to be improved and addressed into it. And for that, we also say for sustainability of the use of this sector, we will use the existing mechanisms in country, which is district coordination meeting. And we know in each of the countries, some of them do it monthly, others do it quarterly. So we said, okay, let us use this existing. And the first thing that we do, whenever we implement it, we need to assess and see how the people perceived it and how the people are using these applications. And later on, we will do a post-assessment. But that, and in between the post-assessment, we go for supervision visit to see how that works. And the objective of this, the assessment that we were doing is to document the use of the mobile, as I said before, and identify barriers to the use of the mobile and determine also the existing decision-making mechanism that exists at the facility level, if there is one, and formulate a recommendation for better use of the mobile app. So what we did is to be looking at a quasi-experimental study, but it's just a small one. It's not a bigger one. Like we said, okay, let's do an experimental and control groups. So we have experimental group where we trained the health facility providers to be using the apps, and also where we know that they have tablets and they have 3G or 4G internet connections so that they have that ability. And the control group where they were not trained, they don't know nothing about the applications, and they are doing their own mechanisms of decision making. We wanted to make sure. And then we use both qualitative and quantitative method. So the sample size that we created because of budget restraint and whatever, we said, okay, in the first district, we have 42 health facilities that were trained and implemented. That is a district where we are piloting it. But others, we said, okay, and among these ones, we just took 27. And the other group, we just said, look at the country widely and said, okay, let us see what is going on in 12 other countries where these applications was not implemented. And we did, like I said, supervision visit in 39 health facilities in the experimental group. And so these are the data collection tools that we use. One will be on the use of mobile apps, what they think about it. And the other one, what existing decision-making processes are in the health facility level. And then focus group discussions with district and regional levels. So the first thing we looked at, when we assessed, we looked at what is the availability of electricity in both. So you see that the figure, the numbers are very low. And so do they have equipments? The internet that you see here is landline internet. And you see also what we were thinking, it's not really what is in the country. And then most of them, in each group, they have tablets. Of course, the experimental group, we were expecting that because this is one of the criteria why they were selected. And so the health provider also have smartphones. So half of the health facilities that we visited, we find that they have it. So when we asked them, what are the mechanisms that you use to identify problems? So all of them, they said, we have data review with community health workers and community leaders. And so where we implemented the malaria mobile apps, they also, half of these facilities use them to identify if they have problems. But why half of them? Because it's only for malaria, because other programs, they may not be using it. And also they were limited, some of them, even if they have 3G or 4G, the tablets that they are using, the versions are 5 and less. So to download these applications will take time for them with the internet. The speed of the internet that they have also wasn't enough for them to be using it. That's why we have only half of these facilities where we are implementing with. And then for them, so what they use to review data. So you see some of them have already an application that was developed by WHO. Others were using still the malaria mobile apps. And most of them, while they were not all using the mobile, and because it's not only, when they review the data, it's not only for malaria, they do it for all programs. That's why even though the control group, they were using the data collection tools, they were using the reporting tools, and also they were using flip chart paper dashboard where they draw manually the graphs and tables. And so on the perceptions of the output of the key in the experiment, so 22% of them said, okay, that will help them to visualize the result. And 37 said it's easy to use with the internet. And that this assessment was done in September, just 3 months after, because this application was implemented in August. And September, November, we did an assessment to see what are the perceptions of using it. And it also, many of them said it facilitated. And if you look at on green, it's the quotation that we took from the focus group discussions. And so the use of malaria, so when we assessed them in February also, we did the supervision in February, we realized that really the way that they did, how the access of information, how it was very helpful to them. So for visualizing their performance or visualizing the trends, and also displaying data for decision making. So it has increased over between November and February also. So you can see the figures by yourself and what the quotation said here. So, and the other things also, when we ask them, what are the mobile application effect on service delivery? So most of them, they said it improved, half of them said it improves the service delivery because they're still using it. But why also these things I'm telling you, when we did the first assessment, so the district took the result of this assessment to advocate for increase of internet and having also for tablets. WHO reacted immediately for that as a partner, offered for the 42 health facilities that we trained, new tablets, version 10, and also internet connection, 3G, for each month so that they can use this to review their data. Okay. So that was, and a recipient of Global Fund, which is the partner coordination unit at the Ministry of Health, also is working with the National Malaria Program to implement that or to scale up these applications in non-USAID supported regions. So, and you see many of them that also it improved the commodity stock. And then that also, because we insisted and emphasized that whenever they see problems, they need to develop a plan of action, which you see the numbers when we came, what we found it. And so now, if you look at when we did the February trade, so 33% of the recommendations that were in the plan of actions were executed by the health facilities. And so you will see the figures by yourself. And so when looking at the apps from baseline August to February 22, so you see how figures has really improved for the indicators that were there. And this was the 13 health facilities that was shown with issues, because the scorecard can display the score of each performances on red. If it is red, it's really something needed action. If it is yellow, it's improved a little bit. And if it is green, it's well performed. And then when they look at it, so if you look at the row number 3, so 182 cases of malaria were counted between the age of 16 and 13. And then on October, we found 420 that we were questioning. Is it an underperformance, or is it really something that key? Because if the data quality is an issue there. So when they went, they found it was a data quality issues that helped the facility to correct them easily. So, and if you look at the graph, many of them are making really progress. And now we have, in February, we have 2 issues with the IPT3, and the district is working with the health facilities to find out what are the problems. So the conclusions, what we said, the selected indicators could help health facilities to monitor really the prevention, testing, and treatment and commodity stocks. And it is also good tools also to improve the accessibility of data at the health facility. And also it improved also the service delivery as well as stock data. It increased also, the recommendation is to increase availability of materials and equipment for a better use of mobile, and improve also the mobile apps result output display, which we worked out because when we realized that some of them made a lot of feedback on how the outputs are displayed into. So now if you look at the scorecard, unfortunately, we cannot showcase here, but those who are interested on it could contact us and we will tell them. And the other thing that I said, to scale up the mobile health facilities, that is the next step that we are doing now, and increase access to mobile internet to health facilities, and advocate for availability of tablets and smartphone or Android version to speed graph and scorecard, review analysis, and use always the existing coordination meeting to make that sustainable in terms of use. And so look at the plan of actions. So just the culture of having plan of actions whenever problems are identified, and increase also the health provider accountability to health facility performance result. So that's what I'm sorry, I think that I was over time, but I'm sorry for that. And thank you very much.
Thank you, Moussa. It was great, and actually very interesting data on how people consume data in the field and how they use it. I think that's very useful for everybody. So now we've seen, talked about training and how people actually use data in the field. And our third speaker will talk about an issue that is often raised about, how to best use data and the challenges to use data that comes from at field level, which is data quality. So Aaron has been working on methods to identify poor quality data, and he'll be showing some, advanced methods that he's been developing to be thinking about data quality from routine health systems. Aaron, the floor is yours.
Yeah, can you see my slides fine?
Yes, very well.
Great. Thank you, Gregoire, for the introduction, and thank you everyone for joining. I am Aaron Fan from Brown University, and I've been working with UNICEF in various kinds of data analysis projects with a focus in integrated outbreak analytics. Today, I will share my experience working with data quality issues, in particular, how to address missing values that often present in routine health information systems. So as we all know, missing data is such a common problem that presents in all kinds of data. In the context of RHIS data sets, here is an example from DRC where we see the missing percentage clearly goes down over time, which indicates an improvement of data quality over years. But it still appears to be a big problem with about 20% missing values in health posts by now. And different health indicators can have very different amounts of missing values and different missing patterns. So this is a call for a systematic way to address missing values across hundreds of health-related indicators from RHIS datasets. However, even though missing value is such a common problem, a recent systematic review found that about 75% of the published papers that involved the use of RHIS data had no description at all on how missing values were managed in their studies. Among those that did mention their missing handling strategy, the very vast majority of them simply excluded facilities based on certain exclusion rule. For example, a lot of papers simply removed any facilities with more than 3 or 4 missing data points. To see why this can be concerning, let's consider this example of an interrupted time series study, which is one of the most popular study designs among the use of RHIS data. Say we want to evaluate the effect of certain intervention that can be a new policy, an outbreak, a treatment, etc., where we may use ITS in these situations to compare what's being observed after the intervention to what would have happened in the absence of the intervention, which is also known as the counterfactuals. And this immediate change between what we actually observe and the counterfactuals are usually referred to as the level change effect. So here again, we work with the RHIS data from the DRC. And let's start by seeing how the choice of missing imputation methods could affect our conclusions. The black line here represents the true level change that we would have obtained using the complete data, i.e. without any missing values. And then we intentionally set 15% of those values to missing and regenerate new estimates based on different missing imputation methods. So as we see here, mean imputation, which is the blue line, where we simply replace missing values with the overall average, as well as the exclusion method, the purple line, which is currently the most popular method to deal with missing values, have both produced very biased estimates. So this already provides some evidence to not use these two popular methods. Further, we also examined 4 other commonly used missing value handling algorithms, i.e. random forest, k-nearest neighbor, seasonal decomposition, and multiple imputation. As we can see from this case study, all those 4 methods provide a reasonably well estimate that aligns with the truth. Note that although those methods are kind of considered more advanced, most of them can, however, be implemented very easily with just 1 or 2 lines of codes in R, Python, or Stata. The command or the package to use is listed in the table here. So we definitely recommend using more appropriate missing value handling methods than just replacing everything with the average or simply exclude those facilities. Among those 4 methods, we see that multiple imputation that accounts for the true data structure has provided the most consistent result and the smallest standard error. That is the last one here named MI with 2-level plus sum. It is a 2-level plus sum because our data here are counts of total outpatient visits that are nested within health zones. So another takeaway here is that even with the same multiple imputation method, i.e. comparing 6 and 7, knowledge of your data structure will be really helpful in providing a more consistent estimate and a smaller standard error. For example, if your data are counts like what we had, assuming a multi-level Poisson usually works. If your data are, say, disease outcomes or other types of binary data, then you might want to use a logistic model multiple imputation, all of which can be done quite easily in R using these 2 packages here. For more details, I recommend looking up this publication that we wrote on adjusting missing values in RHIS data if you are interested in leveraging it in your next study. Finally, let's quickly look at how these methods perform with different proportions of missing values in the data. Well, the conclusions does not change much. As we can see, the 2 popular methods, i.e. mean imputation and simple exclusion rule, started to diverge from the true estimate with only 5% missing values in the data. When the missing proportion grows to about 30%, which is actually quite common among RHIS datasets, all of the methods except for multiple imputation with 2-level Poisson has provided a sort of biased result. This again shows the importance of understanding your data structure. All right, let's wrap up. The key takeaways from this talk will be first, to think and think again before discarding or excluding any data. The most popular methods, i.e. excluding facilities based on some simple exclusion rules or setting missing values to the average or the median, often does not work and will harm your analysis. Finally, understanding your data structure can help not only in your study design, but also in other components throughout the data analysis, such as missing value imputation as we've shown here. So thank you very much for listening. I think we have 15 minutes left for a Q&A session. I will be there to answer any questions you might have regarding missing value handling. Thank you.
Thanks, Aaron. It was super interesting. I think now Karen accepted to provide us, a quick discussion of the three presentation you just saw, maybe putting some synthesis and an overall, impression of those discussions, and to kick us off for the discussion we may have, and we still have time for Q&A. Karen.
So thank you so much, Grégoire, and thank you so much to all of our speakers for sharing those really interesting presentations with us today. So just a couple of quick thoughts, and conscious of the fact we only have 15 minutes left in the sessions, I'll make my comments quite brief. When I think about what I think this session is about, which is about using routine data, using data from, for example, DHIS systems to inform what's going on within health systems, I always think of malaria as being sort of the kind of key disease area that really helped to advance this area. Malaria, more so than almost any other disease area, has really emphasized the need for more granular data, for more temporal data, for just basically the quantity of data. And while that's been the focus for a while, I think the 3 presentations we saw today really point to, I think, what are some of the limitations. which is that the quantity of data is simply not enough. And as a community who is really interested in understanding data, interested in using data for health purposes, we really need to think beyond quantity and think about quality. So the 3 sessions, I think, brought up very different aspects to this. So in Burkina, we were learning a lot about the simple need for more training for people who are using these data. And it was really interesting to see this emphasis going into some of the university systems, some of the educational programs that are complementary to what's happening in the health system to train people to use these data. And this is really interesting and important. From our JSI presentation, Dr. Moussa Lee, who presented his work with Madagascar, really sometimes very simple things like visualization of data and providing tools can be incredibly helpful for people to actually see and understand the data. So how do we think about integrating some of that into the way in which we think about using data within healthcare systems? And then finally, Erin shared with us, which I think is a really important piece on understanding some of the methodological improvements that are required to think through some of these issues. The data that we are dealing with in these systems are different than data that might be coming in from more traditional sources, such as household surveys. And I think Erin's presentation really emphasizes the need to better understand these data and also to develop packages and tools that people can use to better use these data. So all of this, I think, really comes together really nicely in the sense of it's been great to see a lot more interest in data disaggregated coming in from local levels to understand issues like malaria. But in terms of moving forward and in terms of really understanding what the next level might be, there is a need to better understand these kind of more user-centered aspects in terms of how do we actually use and put the data into practice. So I think the goal is now to open up into Q&A, and I think Grégoire is going to be managing them. But just to say thank you to the 3 presenters for these 3 really excellent presentations.
Thank you, Karen. I think it was great to tie all those presentations together. So I don't think we've received any questions yet through the chat or the Q&A. So if there are any questions coming from the audience, I don't know if you can raise your hand also from here. So if nobody has a question, maybe I can just throw one question maybe to Boukari and then Moussa, which is reacting to Aaron's presentation showing advanced methods that are now more in a research arena in terms of managing missingness and managing that missingness in a research setting. I think both of you, Boukari and Moussa, are involved in routine utilization of the data, and how do you think and what do you think it would take to have more advanced and better management of missing data for in your daily utilization and in the work that you are doing using data in the field. So I don't know, Boukari, if you want to take that first.
The question is pertaining to the quality and the data. So the question is, how do you think of using these methods by using these missing data for? Excellent question. For data collection now, there is a lot of strategies, but the use is essentially useful for at the level of the service. For the validity, for the use from the service, what we notice is that the actors are more collection actors. And what I think is, from my point of view, we need to look at the primary level. The collection has to be well organized to have good quality, because once you've got that, the actors who supplied the data, the actors who want the data can analyze them.
but the collection phase is the collection should be reliable. But if you can't do that, and you want to use one source with one basis with multi-sources, we're going to find ourselves with missing data at this level. If at a primary level people are not able to apply the correct method for collection of data, in fact, they've got to be aware of the way the data are being analyzed, so that they can actually understand how important the accuracy and the detail, the granularity of the data is important, knowing that without correct data, we can't have useful discourses or discussions and decision making. Thank you. Thank you.
Lisa, I don't know if you want to elaborate on that what Bugai just said about the interaction between the field level management of data quality and then how you scale up and you think you change the way you think about that quality and missingness as you are going up the level of aggregation and utilization. I know how that fits into your experience of working with field level utilization of the data.
Yeah, thank you, Greg. So if I'm taking on this application that we developed, like Bukhari said, it was for us, the first thing is for those who are collecting data to have access to it and to make decisions. And access to it also, if they can have access to this data on real time, that means DHIS2 is already on a platform using the internet. So with this 3G and 4G access internet, so they can see their information. And the information that I was showing you in that graph, in that table of scorecard, you see one of the facilities was saying at one point they were having 170,000 cases of malaria. And then 3 months later, we saw that they were having also in 3 months, 420 cases. So that could be something. I will come back on the missing of the, so this is an issue. Is it underperformance or is it a problem of data? So then we have to go and revisit the data and see what's going on there. So that's what the facility do. At the first time that the facility saw it immediately when the data is entered into the system, so they will go back to their data and look at it. And when they look at it, this is an opportunity for them to be recounting and correcting the aggregation. So that will facilitate also the district level not to be always questioning and asking about the data before even it's data to be validated. And the same process can be used whenever you see that there is really underperform data are really very low. So we may think, okay, there are missing data into that. So how to correct it? And if the facility, health facility, who is collecting the data have the opportunity to be acting and looking at if data are over-reported or under-reported. So if they have that ability to do that, then we can work, we can say, okay, one issues of missing data or over-reporting data can be addressed through making that these mobile applications available at the health facility, even at the community sites. So that's maybe what I wanted to answer on that question.
Thank you. We have 2 minutes remaining. I see that Aaron has been answering also a question in the chat if you want to check on that. Maybe around a last question if there is no, I'm also checking that we don't have any hand raised, I don't think that's the case. So Aaron, maybe to finish, and I think your presentation on the method aspect was interesting. What would you say would be on your end, the next steps to bring that utilization of methods to the field and to benefit routine utilization, and not only think about your approach in the framework of research projects, but also of routine data utilization, and maybe building on your work with UNICEF here.
Yes, thanks, Gregoire. So it is also mentioned in the chat box that Mason said their team don't have a statistician or a data scientist to apply these technical tools in R or Python. So we think it's quite common that research teams don't have such capability to perform these statistical tasks. So as a result, we are actually now working to develop a package that will address various data quality issues, including missing values, extreme values, and also all kinds of evaluation that can be done through a very simple line of codes or like a very user-friendly interface. So we are working on that. I would say stay tuned for a package. Yeah.
Okay. Great. I think that's indeed a very handy way to also share that and share it with analysts. So it's time to conclude the session. And maybe to finish the round, Karen, if you want to I think you did the nice synthesis here and send us off with next steps and final words on the session and give what everybody should take back was.
Yeah, so I'm happy to do that. So great presentations, everyone. Great questions from the ground. Lots of open questions about how to make things better, how to make some of the science, some of the stuff that's coming in from these groups who are doing wonderful things more accessible to others. And I think that is a very big open question. I hope conferences like this help to bridge that gap a little bit. But I also think that there needs to be some way of finding better ways for training, better ways to really thinking through some of these. These are really important questions if we're going to continue to build on this data ecosystem. Who are the users going to be? What are the skills that they need? And who is going to be providing that training? And so I think those are some really important questions. The session couldn't answer that, but I think really was useful in terms of opening up those questions, and hopefully in the future we'll find better answers to those questions.
Thanks very much, Karen. We're 1 minute over time. Thanks everybody for your attention and for your attendance to that session. And don't hesitate to reach out to any other speakers. I'm sure everybody will be very happy to address more questions and precisions about the presentation. Thanks everybody. Have a good day.
Thank you and bye.
Thank you.